Hello, everyone. We are going to let folks file in. Welcome. Thank you for joining us. We see the number still rising. All right. I'll just keep sitting here as folks keep coming in the door. This is great to see so many attendees. We have a wonderful session for you today. I'll actually advance this slide, just one, so you have a sense of what's coming, build some anticipation. All right, it has flowed to a trickle. Welcome everyone. I am Frank Hood, the director of Hep B United, which is a coalition co-run by the Hepatitis B Foundation and APJA. Today is sorry, on the wrong screen. You are here as part of the Be Informed virtual education series about hepatitis B. This is the second session. So this is a newer capacity building program we are offering, but we are thrilled to be offering it, and we are thrilled that you are all here participating in it. So this takes after a similar style to the ECHO program, in that there is a speaker who very much dives into a specific topic, and then we look at that topic through sort of a different lens or through a different sort of specific case study or example, and then we go and have open conversation. You see here it says Q&A, open discussion. That's very much the case. It doesn't necessarily have to be question and answer, but suggestions and thoughts and comments as well. So today, in addition, I wanted to note that at the end of today's session, there will be 4 survey questions that pop up. Please take the time to answer those. It really helps us gather the feedback that we need to continue to improve upon this session. And please be honest. If you did or didn't like something, that really does help us ahead of our next session, which will be in 2 months. And we have that date coming up on a separate slide. If this is your first session with Be Informed, then I wanted to welcome. This is a series that's geared really towards anyone who is interested in learning about hepatitis B. That can be family members of those living with the disease, patients themselves, or public health advocates. And as I mentioned already, really working this through a kind of a didactic approach. And this capacity building program is brought to you by a CDC cooperative agreement. I mentioned about Hep B United earlier. I wanted to say that we are a coalition of coalitions, and so we have quite a widespread. We are continuing to grow, just introduced 2 new partners representing 2 new cities in the last month. So if you are working on hepatitis B or a coalition working on hepatitis B and you aren't a member of Hep B United, please reach out to me or Shreya, even right here in the chat, or shoot me an email. Our email address will be up in a moment, because we would love to have a conversation about what we do and what we offer, and how we would love to have you kind of folded into that work and bring you along as part of our growing and very impactful coalition. So this is webinar setting. I'm sure many of you are old hat at Zoom, but if you are not, do know that you are on mute, so you don't have to worry about that. Do feel free to use the chat feature, and please put questions in the Q&A the question and answer box. We do try to answer all questions, whether it's on air or privately, and if there are questions that we haven't had answered, we'd like to grab those and try to follow up with you afterwards. So if you would like us to follow up with your question, make sure to give us your name. I think there's an anonymous thing, so just if you want an answer, we are able to get to it, don't be anonymous because we'll come back to you. So today we are talking about eliminating hepatitis B and really how it's possible, what's happening, what are the barriers, what it actually looks like. And that is being done by the president of the Hepatitis B Foundation, Dr. Chari Cohen, who has many, many years of experience working on the issue of hepatitis B. And then after that session, we are going to turn it over to another colleague of mine, Dr. Freeland, who is going to look at, or who's going to share out some findings of some qualitative interviews that she had, she and a group she's working with had with harm reductionists and others around the barriers to hepatitis B services in those settings. I know that has been a community that many are hoping to serve, and hepatitis B is not being addressed much in that community. And so I think some of what you'll hear today will be very, very impactful. Additionally, I just got to brag that my colleagues are awesome. I understand I work here. I'm not just saying this because Chari is my boss, but legitimately, my colleagues are awesome. Chari and Catherine are a wealth of knowledge. So please, if you have a question, drop it in the chat or in the box because you want them to answer it. And if they don't know the answer, they likely know someone who will. So use them as the resource they are. Let me see what's next. Oh, nope. And so with that introduction, I'm going to turn it over to Chari and let me know if you have any trouble sharing your screen.
Thank you, Frank. I may have trouble sharing my screen. There it is. Okay, can you see?
Yes.
Okay, perfect. Thank you so much. And thank you, Frank, and thank you everyone for being here today. I'm really happy to talk a little bit about what's happening on the ground in terms of hepatitis B elimination in the US. I've been given about 15 minutes, and I know that I certainly can't do this topic justice in that time. So I'm going to do more of a high-level overview. But everyone has my email address and my phone number and can certainly easily find me and would be happy to talk more, answer more questions, or chat about anything specific that anyone wants to go over in the future. So why are we talking about eliminating hepatitis B in the US now? Well, you all know the numbers. We have about 2.5 million people, or up to 2.4 million people, are estimated to be living with chronic Hep B in the US. The problem in the United States, which kind of mimics what is happening around the world, is that most people who have chronic hepatitis B infection have not been diagnosed, and most adults have not been vaccinated. So what we see is a situation where people aren't being diagnosed, so they're not being able to access care and take advantage of the treatment that is available to prevent liver cancer and cirrhosis. And then among high-risk adults and among other adults living around the US, we have very low vaccination rates. And so we are not preventing people from getting infections. And what we're seeing because of that is an increase in infections. Just move to the next slide. So we have not appreciably seen chronic hepatitis B in the US go down. And now we're actually starting to see acute hepatitis B go up in the last number of years, primarily associated with people in the communities where people are experiencing homelessness and people are injecting drugs. And that just goes to show that we are not doing a great job with vaccinating adults. And there are many unprotected people still in the US. We also know from at least one study that was done in Minnesota that looked at liver cancer diagnoses in a couple of different communities between 2000 and 2014. And what they found was that the proportion of liver cancer due to hepatitis B in the US had grown in those communities from 4% to 21%. And that's the only study I've ever seen of its kind, but I wouldn't be surprised if it's indicative of a trend. So at the same time, we're not diagnosing folks enough, we're not vaccinating folks enough, and we are now seeing a lot more liver cancer. And I suspect we'll continue to see more liver cancer due to hepatitis B. We've also not greatly improved the care cascade among highly impacted communities. So we haven't been able to address the health disparities to a significant extent. We have seen progress. We've definitely seen progress in terms of liver cancer, in terms of hepatitis B diagnosis and vaccination among some of the highly impacted communities, but not significant progress and not enough that we can meet the elimination goals by 2030. We also know that we can prevent hundreds of thousands of deaths and improve the lives of millions of people just in the US. We know that we have a lot of the resources we need to eliminate hepatitis B. We don't have everything. We know that we don't have everything. We don't have a cure yet. We don't have point of care testing, which I think would make us a significant difference. But I will say that we have so many more resources now than we had 15 years ago, 10 years ago, 3 years ago. We have effective vaccines. We have partners, as Frank showed in the map, we have partners in almost every state across the US that are working on hepatitis B to some extent. We have very good treatments that decrease the risk of liver cancer. And now we have these really, really great universal strategies and recommendations that we are using to build sort of multilingual, multi-platform resources that we can use to make elimination something that we can actually reach in the US. So just to put it into context, it's not just the US working towards eliminating hepatitis B, it's the globe that's working towards elimination of hepatitis B and hepatitis C. And I think we've all been talking about it a little bit, but the world's working towards viral hepatitis elimination, and that means we should be too. We do have the World Health Organization report from 2017, which talks about their global commitment to reducing new infections, to reducing mortality due to hepatitis B and C, and to increasing the number of people across the world that are protected. We also have the HHS Viral Hepatitis National Strategic Plan, which is very US focused. And it talks about preventing new infections, improving surveillance, reducing chronic and acute infections, and creating coordinated efforts to eliminate viral hepatitis as part of a syndemic approach, which I think is very important too, because we're now starting to, we know the benefits of not treating some of these diseases and conditions in silos, and to really making sure that we are using syndemic approaches. And that means working towards elimination of multiple conditions that are impacting communities, because it saves resources and it saves lives. We also have state elimination plans that are happening around the country. And what we see is that from the HHS Viral Hepatitis National Strategic Plan, and with some state and federal funding, we see states around the US creating their own elimination plans. Pennsylvania has one, and I'm very proud that the foundation helped to, was part of the creation of the elimination plan and part of the leadership for the coalition that goes along with that. I think some elimination plans around the US, if we look, some of them are just for Hep C elimination. Some of them are for both B and C elimination. Of course, we want to see hepatitis B included in every state elimination plan. But we do see a lot more states now that have elimination plans than had them a few years ago. And some of them are even funded. When I talk about the new recommendations and that we have now for hepatitis B in the US, this is what I'm talking about, and these are huge. These are incredible new resources that we have that will help us get people screened and get people vaccinated and save lives. So we now have universal adult hepatitis B screening and a recommendation from CDC that states that every adult in the US should be tested at least once for hepatitis B, and that pregnant people should be screened during each pregnancy, regardless of vaccine status and regardless of past history of testing. We also see in this recommendation that there are recommendations for expanded periodic risk-based testing, and that's for people who are at higher risk for hepatitis B. So for example, people who have hepatitis C infection, people who have a history of STIs or multiple sex partners, people who are incarcerated should potentially be tested more than once based on risk. And then I think the beautiful thing about these recommendations is that it takes away risk disclosure, right? It makes it very, very easy to offer someone a hepatitis B screen without having to worry about asking them for whatever risk they had and without them having to disclose what risks they have. We are also very grateful to have the universal vaccination recommendation for adults, which says to vaccinate all adults in the US age 19 to 59. All adults 60 or over who have at least one risk factor, or, and this is another great part, any adult who wants to be vaccinated and protected against hepatitis B. And so these new recommendations provide us with a tremendous opportunity to get people protected through vaccination in the US and to get people diagnosed and then linked to care and treatment and liver cancer screening. So what are we doing now that we have this tremendous opportunity? Well, I think I don't know the folks who are on this right now, but I think probably most of the people who are on this are doing one of these things. There is quite a tremendous amount of activity now happening around the US towards using the new recommendations and making change happen and towards elimination. This is a lot, and I can't go through it all, but what I can say is that there are very strategic activities that are happening at the federal level, the state level, and then in communities and among and within health systems. From a federal and state perspective, there's quite a lot of advocacy and programmatic work done to improve and enhance vaccination and screening access, working on vaccine procurement, working on advocating for point-of-care testing in the US, advocating treatment access and trying to eliminate discriminatory drug pricing with our federal and state partners, advocating to the USPS, United States Preventive Services Task Force, to align with the screening recommendations from CDC. All of this is kind of geared towards increasing and expanding where people can be vaccinated and where people can be tested in the US. And we hope that with all this work, a lot's going to happen. As I mentioned, there's quite a lot of state elimination planning happening, and the health departments have been incredible in leading that effort. Many of our Hep United partners around the country are also working on state elimination planning. We're also starting to see micro-elimination sites as well, where there are distinct projects trying to eliminate hepatitis B in small communities around the US, and in newer communities that haven't historically been focused on for hepatitis B screening, vaccination, and linkage to care. And Catherine's going to tell you a little bit about that, about some of that work and some of the work that needs to get done. We are very, very actively working to disseminate and integrate the new vaccination and screening recommendations, working towards health systems level change, doing things like working with health systems to see how we can integrate into electronic health records, how we can create quality measures, both for vaccination and for screening. Working on provider education. And I think when we talk, if you look at these last few bullets, provider education, patient awareness, community awareness, for the last 20 years, we've been doing this in a targeted approach, right? Because the recommendations were targeted towards specific high-risk communities. Well, now we can do this for every community. And so for the paradigm shift for us now is educating all providers, right? Primary care providers in settings that are not necessarily just seeing high-risk communities. And that offers us a tremendous opportunity to improve awareness among the general community in the US and improve awareness among different providers to help them understand that they can screen and they can vaccinate. And I think we're also spending quite a lot more time now raising the profile and rate of people living with hepatitis B and raising their voices, because we know that people with lived experience should be playing a role at the table. And we're very happy to have folks around the country helping with that as well. I'm going to end with a couple challenges. As you know, we do have some challenges. We continue to see a lack of prioritization that impacts the lack of inclusion of hepatitis B, both in funding, in elimination plans, and I think locally, regionally, and nationally across the US. And of course, we are all working to try and overcome that. We also see access to screening and vaccination is an issue. I think until we have US Preventive Services Task Force aligned with the CDC recommendations, screening access might continue to be an issue. And we also know that adult vaccination is a challenge. I think both from an awareness perspective, a prioritization perspective, but also from a funding perspective, we are competing with a lot of other conditions, other diseases, other vaccinations, and we have to make sure that there are vaccinations for everyone that wants one, and so that we can protect the US. We are also seeing access to treatment issues, and I know for anyone who has followed us or is in our newsletters, you've seen that this is happening. We are seeing health insurance companies and pharmacy benefit managers decreasing access to treatments or denying specific treatments and really limiting the options that people living with hepatitis B have. And we are very, very strongly advocating and working with other partners to try and see what kind of policy change we can, or what kind of change we can implement there. And of course, because we have for the last 20 years been really targeting high-risk communities and the providers who serve them, we have now lots of low awareness among general practitioners and the general community, which we have to find a way to overcome. And finally, I will say, we are, I think we as a community in Hep B do incredible work with a very small amount of funding, because we're smart, we're dedicated, and we won't take no for an answer. But I do think we're going to need to see some more funding and public health infrastructure. And I think that potentially COVID-19 helped to build some of that infrastructure and funding, and hopefully we will be able to leverage that into the future. And before I leave and hand it over to Catherine, I just want to share that we have this call to action out. So this is actually a white paper. The Hepatitis B Foundation hosted it's like a 25-person Hep B screening and vaccine advisory council with experts from around the US, and basically put this paper together that talks about how we can get people screened and vaccinated in the US. And it talks about the importance of screening and vaccination, what some of the challenges are specifically in different settings, and what some of the resources we have are, and how we can kind of move forward together. So with that, again, I know it was a lot, and I really just wanted to kind of set the stage for Catherine, but I am always around and available if anybody wants to talk about any of these specific areas. So I'm gonna stop share and put myself on mute and hand it over to Dr. Freeland.
And let us know if you have any troubles getting your screen shared. Oh, here it goes. All right, take it away, Catherine.
Okay, great. Thanks so much for the invitation and for Chari to set the scene for what I'll be talking about. I'm really going to be focusing on some work that we've been doing that's been supported by Hep B United and the Hepatitis B Foundation, as well as some colleagues at HepTrek, which is an organization that really focuses on comprehensive harm reduction services. It's located at Prevention Point, Philadelphia. So some of the things that I'll be talking about are specifically within the space of harm reduction. So a subpopulation where we know there's risk factors for hepatitis B. And I definitely want to acknowledge my colleagues who have been really instrumental at making sure this work moves forward. Dr. Amy Jessup and Melissa Lamb, who've helped with the interviews that I'll be discussing and the results, and worked with me to compile the thematic findings from this analysis. So in the United States, it's estimated that about 3.7 million people injected drugs in 2018, and this is likely an underestimate, and likely COVID-19 has kind of expanded this number pretty significantly. And with injection drug use, there's a direct risk for hepatitis B transmission. Additionally, other risky behaviors like transactional sex or unprotected sex, or where there's an exposure through blood or open wound, is also risk factor for hepatitis B transmission, and is also common risk factors really within this population that we're talking about. Also in the United States, we've seen changes in drug patterns. Fentanyl is the primary opioid that's in most markets, and this leads to increased frequency of injection as well. We're also seeing xylazine, a tranquilizer, into the market as well, which is a big challenge. There's been increases in the number of sterile syringes needed per day per person to prevent infection, but the frequency of infection is really increasing across the board in this population. And in the US, we had about 2.4 million with hepatitis B, as Chari described earlier. And oftentimes folks that are injecting are often hard to reach. They're often very transient. They also may not have direct access to healthcare testing for hepatitis B. And so what we did to really kind of better understand what was actually happening in the US related to the harm reduction space and hepatitis B was really look at what was taking place within harm reduction activities and examine hepatitis B related activities specifically, understand the barriers and facilitators to these activities, and then work towards contributing to the needs to really figure out how we can better improve harm reduction activities in the space of hepatitis B. Sorry. Okay. So to do this, we created semi-structured interview guide that was informed by published literature and expert consultation. We piloted the interview content with 2 harm reduction agency leaders, and we recruited leaders through a couple of listservs that are within the harm reduction setting in the US. As a result, we reached out to 20 or more, about 20 individuals that were interviewed between December 2022 and February 2023. These lasted for between 30 to 45 minutes. They were recorded and transcribed and then analyzed through a qualitative and analyzed software called In Vivo. We had 2 coders as well and wanted to reach a coding agreement and identified overarching themes from the data itself. We had 20 participants, and these were executive directors, medical directors, and program directors representing 20 agencies, 18 states, including DC. They were small, medium, and large agencies. So you can see we tried to create some sort of diversity from the represented organizations that were interviewed. Some were brick and mortar shops, while others were mobile, and some were legal, and some were not legal. From the interviews, we found that hepatitis B specific activities were very limited within this setting, even within agencies that are providing medical services on site. Much of the medical services that are currently being provided on site are HIV or hepatitis C specific. Hepatitis B generally was low priority. There was limited knowledge and awareness among both the staff and the clients of hepatitis B, and organizational capacity to include hepatitis B services were limited. There's also an impact of laws and policies related to hepatitis B services. We found that health departments were really instrumental in identifying the priorities for harm reduction, either because of the funding streams or because of some of the health services that they could help in supporting these agencies. And we'll get into that in a little bit. And then partnerships were really essential for the adaptation and adoption of hepatitis B related activities. So the following I'll just be presenting as these overarching themes that were presented on the previous slide, and dive in a little bit deeper. And at the bottom of each of these next couple of slides, you'll see specific quotes that really kind of demonstrate that theme. So I won't read those directly, but hope you'll take some time to kind of understand what exactly we're talking about through those quotes itself. So in terms of the hepatitis B related activities, most organizations that we interviewed did not have any activities ongoing related to hepatitis B. If they did have activities going on, they were around education. So taking out materials, talking about it, or handing out content to participants within their spaces. A majority of this education was also usually in conjunction with hepatitis C, or all of the other hepatitis, so hepatitis A through C were included. Or it was generally about safe use information. Vaccinations were next on the list of things that were talked about, but these were usually in conjunction with a partner organization like a health department or a provider or a partner. And these were also often done more frequently when there was like an outbreak going on. So, there's been a lot of hepatitis A outbreaks in some of these settings. So with that came an increase in education in this setting. Most organizations, again, don't conduct these activities or have limited hepatitis B activities. So really there's an opportunity to think about how we can integrate hepatitis B activities within this setting. In terms of knowledge and awareness, there was really low level awareness and knowledge. There were a few representatives that didn't seem to recognize hepatitis B. Oftentimes when we were interviewing them, they started talking about hepatitis C in that conversation. And so you could tell that just really the lack of basic understanding of hepatitis B was really low. Many didn't know about specific vaccines, testing, or treatment challenges that may exist. And only a handful had actual extensive knowledge, but also said that most of their staff within their organization did not have that knowledge. The impact of partnerships was a really interesting driver of both perception, priorities, and actions related to hepatitis B. Agencies that had strong ties to health departments, they tended to have better access to resources. However, health department communication about the importance of hepatitis B did influence what the agency was doing. So if the health department didn't deem hepatitis B a priority for this populations that they're serving, then that organization would not be conducting much in terms of the activities because it wasn't echoed down to them from their health department. Infrastructure for vaccination and testing was also influenced by health department collaboration. Much of those resources were provided by the health department if they were provided at all. So that relationship is really important, and that top-down partnership approach for medical resources, like, for example, hepatitis B vaccination, was something that the health department needed to prioritize in order for it to be done at the harm reduction site. Overall, most agencies do not see hepatitis B as a significant health issue for their participants. Some of these perceptions, again, were drawn from those health departments locally. They were told that there was no hepatitis B in the area, but again, when asked, are they actually testing for hepatitis B? The answer again is no. So if you're not testing for hepatitis B, you're going to have the answer that there is no hepatitis B in the area. So there really needs to be some consideration at really understanding the population burden within these subpopulations for within the harm reduction space. More communication about HCV and HIV were included, and they also just assumed, because that communication coming from the health department focused on those two things, hepatitis B wasn't an issue because it wasn't included in that communication from the health department. It also is not included in all elimination plans as well. A lot of the elimination plans on the ground are focused on hepatitis C, and because hepatitis B is often not included in those, or sometimes not included in those plans, it's often left out of these conversations. Organizational capacity was another big issue for this setting. Like Chari mentioned, funding and resources are always a challenge for really equipment, supplies, and staffing. The fact that hepatitis B is a blood draw was a really significant barrier for a lot of these organizations as well. A lot of the providers or staff don't have the capacity to draw blood every time someone comes in. Additionally, the capacity of mobile units, some organizations are just doing needle exchange out of the back of their van, and oftentimes it may be underground. So adding on a service like a blood draw is really not feasible for them at this time. Additionally, referral to providers is something that was a challenge. So, if they did test for hepatitis B, if somebody tests positive or needs vaccine, that linkage to care would be a really big barrier for people in this setting. And I think at play overall within this setting is stigma, both internal within harm reduction agencies and external towards drug use, and people who use drugs really impacts the priorities overall. Many people believe that their participants aren't concerned about hepatitis B or vaccination because they're really just trying to survive. And this entails finding their next meal, drinking water, finding a safe place to sleep that night, Narcan, and that sort of thing. But they do offer HIV and hepatitis C services and related activities. So it's really about like resource allocation and how we can work towards integrating hepatitis B within these HCV and HIV contexts, because for all of them, there are a lot of opportunities for overlap as well. And then finally, policy barriers are a challenge in this setting. There's really lack of prioritization of hepatitis B as an issue by local and state health departments. Not all states have elimination plans, and there's also, with that, a lack of hepatitis B related resources to these agencies, if any at all. There's limited vaccination availability, particularly for insured patients or underinsured patients, and insured individuals are not being vaccinated through traditional means. Vaccination requirements as well limit participation and impact the ability to enter or check previous vaccinations. Oftentimes, prisons or correctional facilities don't enter vaccination information, so you may not have the most accurate details of whether or not a person was immunized or not. One really big challenge was the lack of point of care testing in the United States, and that requirement for a blood draw for hepatitis B, which prevents testing opportunities. And then the need to return for test results, because this is often a transient population. it's difficult to connect them either both with follow-up care and also to testing or vaccination as needed. Point of care could certainly help with this, especially if it was a rapid type of test. But again, that linkage to care would still need to be really emphasized in hepatitis B related activities. And then Medicaid expansion and renewal of Medicaid challenges. Oftentimes payment for care is not reimbursable, or there's drop coverage with renewal issues there as well. And so in conclusion, harm reduction organizations, they do offer the opportunity for people to be met where they are in terms of the health services that can be provided for them. And they work with people who are hard to reach, often unhoused or unstably housed. Could be sex workers or other vulnerable populations. So it's really important to consider them as an opportune organization to work in the space of hepatitis B. And from all of this work, we found several recommendations that we think would be impactful to help address this. All of the issues that were presented. And this is really increasing education about hepatitis B, develop hepatitis B educational material, think about how health departments and the CDC could expand hepatitis B vaccination availability, include hepatitis B within viral hepatitis plans, which is something we're already really working on, include and prioritize by local and state health departments, hepatitis B attention and resources, and then ensuring testing is more accessible for those that are in need of it, particularly among these high-risk groups. Just want to acknowledge some folks who helped with this project and then references, and then I will end there and happy to answer any questions.
Thank you. Catherine, do you want to cancel your screen share? Thank you. So first off, so thank you both, Catherine and Chari, and folks, please keep putting in your questions in the Q&A box. I did actually want to bring up one question that was asked. So we had a question about specific language resources, but it seems as though one of the big barriers around eliminating hepatitis B is the fact that because it's so widespread and impacts so many different communities, it has to be communicated in so many different ways. What are some of the ways that you all actively tackle? I'm going to ask this question, and then I have to do a follow-up. What are some of the ways you actively tackle these language barriers? And as you answer that, I will tell folks that in the chat, I am entering links to both the Hep B website and the Foundation's website that does have some translated materials as well. So do take a look at that to see if that helps your needs. But Chari, how do we tackle this?
Sure, I can start and then hand it over to Catherine. I think we've all done quite a lot of what we do is public health research. And part of that is working in specific communities to find out from these communities how they like to learn and specifically how they want to learn about hepatitis B. And then we design communications to give people what they want, basically. And so we do and are working on creation of multiple communication campaigns in many, many different languages. But not only translating them, I mean, we actually will create communications in language and using a lot of the cultural sensitivities, a lot of the tips that we get from different communities around the world on these are the kinds of things you should say, and this is what it should look like, and this is what it shouldn't look like, and don't talk about this. And so we're pretty sensitive in what we create, and it's not just us at the foundation, it's all of our partners that work in the US around hepatitis B and honestly around the world. We're all creating multiple platforms. So there's videos, there's infographics. We're working on these new vignettes, right, which kind of walks people through images, through the different patient stories. There's multiple different ways of reaching communities. I think the key is that what we are trying to do now is make sure that we are training health educators, lay health leaders, and community leaders so that they can then, it's not, what we don't want is just not like people going to social media and seeing posts, right? If you want to use a lot of these resources, you have to kind of work to train and improve capacity at the ground to be talking about Hep B more.
And I think building off of what Chari said, I think from what we learned from this project, there is a clear need for more resources and content directed to the harm reduction community, whether it be looking at risk factors for acquiring hepatitis B or including it within other diseases like HIV or Hep C, for example, just to think about prevention and also just testing and the importance of knowing one's status in this context. So I think one of our next steps for this project is really thinking about what sort of content we can create that will be appropriate for this population, because there's really limited resources out there in this setting. And so that's really our next step, is to try to continue to address that. And I'm sure we'll be thinking about what languages will be appropriate for that as well.
Catherine, on the interviews, there seemed to be quite a bit of, we don't have the knowledge or the capacity, but was there sort of the willingness to go and improve the knowledge and capacity if they had the resources, or a little bit easier, things were just a little bit easier to be able to do those?
Yeah, I think so. I think, people want to do what's best for the communities that they're serving, particularly in this setting. I think if there's an opportunity for resources to be allocated to help people make that happen, that would certainly be helpful. I think people are receptive to learning as well about hepatitis B. I think the problem is that people don't necessarily understand the impact that it has in the community, because that testing necessarily hasn't been done. And so I think it's really important to start where we are now, knowing that we know the risk factors for hepatitis B are really present in this community. So how do we address it and overcome these challenges with people not understanding the true prevalence in that setting? And then going from there. But I think there's a lot of work to do, and we are kind of starting from really a baseline level to really try to figure out how we can address it from multiple factors. It's the prioritization at the health department. It's also just making sure that these organizations are aware of the importance of hepatitis B screening and vaccination is really key.
Chari, you had mentioned in your presentation about the need to really not do this work in a silo, to wherever there are the touch points with other diseases or whatever, not whatever, other medical touch points, to make sure that hepatitis B was present there. What are some of do you have success stories in your time on the ground there in Pennsylvania around seeing some of that crossover really be fruitful?
Yeah, sure. I mean, Catherine can talk more about, because she's on the ground in Philadelphia, but I mean, during and since the COVID pandemic, we host flu clinics with the health department and partners in Philadelphia that are COVID and Hep B vaccines. So we're hosting at the same time. So that's just one area that it can work. But even in Philadelphia, in the last number of years, we've done education and screening together for Hep B and C, where we'll go into communities and we'll do a couple of minutes of education on both, and then we offer screening for both. Now, we've done it both ways, where we would offer the blood test for both B and C, and there are times where we also had like the oral swabs. So we did like Hep B blood, roll up your sleeve for Hep B and swab your cheek for C. So there are some, I mean, I think those are small examples, and they do work. But I think the important thing to remember is when you build public health infrastructure and you're using the same strategies and you're working in the same communities, you just get more bang for your buck if you are focusing on multiple conditions that can be addressed at the same time. We know that it works. The syndemic approach is not new. And I think, one of the things that we see now, where we have the White House proposing a Hep C elimination plan. Well, I'd love to see a viral hepatitis elimination plan, because the strategies are the same, the communities are the same, the testing is the same, the linkage to care is the same. There's so much crossover. And even when I think about HIV, so much crossover. For goodness sakes, it's the same treatment. So yeah, I think it just makes sense from a public health perspective and from a saving lives perspective.
Catherine, have you done specific B screens or vaccination clinics at like HIV clinics or other pieces?
We're about to start, well, we've done work with a harm reduction organization in Philadelphia called Prevention Point, and we tested for all the hepatitis, so A, B, C, and D, to really just try to understand like what's the prevalence, how much of the population has been vaccinated. And we've also done work with different partner organizations that have combined these resources. So we'll go out to do like a community health fair and we'll do Hep B and C testing. And then another organization that has the expertise on HIV will add that in.
Nice.
We haven't done the HIV specifically though. But I will say one thing that does help when we're out in the community is if we're able to go to like a broader like health fair or resource fair with the community, that tends to help because oftentimes people might not come out just for hepatitis screening, but they may come out for, you know, a lunch or and plus blood pressure and BMI and all these other health resources. So like it helps to combine it with other things that are maybe a little less stigmatized to really like meet a larger group of people that probably do need the service.
Great.
Frank, do you mind if I just add one more quick thing? I think that the thing that I want to think that we can use to sort of effectively frame all of this around is liver cancer prevention. We are preventing liver cancer. And I know that this is true for both hepatitis B and hepatitis C, but in particular, when we're talking about hepatitis B vaccination and hepatitis B testing at linkage to care, the reason we're doing it is to prevent people from getting and dying of liver cancer. And I think that's a really powerful message that we perhaps have not used enough in our education and our policy work and our advocacy work. And I know from the Hep B Foundation's perspective, we're starting to think about changing that. And we have in the past couple of years. The liver cancer message, I think, will help us do our work more effectively and help people to understand, why is Hep B important? Well, it causes liver cancer and nobody wants that.
We are a couple minutes past our planned time, but there's a question here that I feel like is the one we should end on. So it asks, is there any way to eradicate hepatitis B? But I'll ask a little bit more like, can we eliminate hepatitis B? Chari and Catherine.
So this is a conversation I used to have with Dr. Blumberg all the time, who didn't really feel like eradication of disease was from a public health perspective, feasible or cost effective, because eradication means eliminating every single case from the earth ever. And that's really hard to do. We've only done it once with smallpox. And those last few cases probably were, you're spending hundreds of thousands of dollars to prevent one case at that point. So this is why we are eliminating hepatitis B, because eliminating hepatitis B will get you down to such a low point where you're barely seeing new infections. The people who have current infections are being managed and treated, and you see such high vaccination and prevention rates that generation to generation, it's not an issue anymore. I think we can eliminate hepatitis B. Do I think with the current infrastructure and current prioritization, we're going to get there by 2030? Probably not. I think we're going to see significant progress, and we're going to keep working at it until we do eliminate it. So yeah, I think we'll get there.
Yeah, just building off what Chari said, I echo all of those things. And I also think that to get there, we also need more resources and just like prioritization at all levels, because there are so many gaps in all of the care cascade that are, you know, it will take us a long way before we actually get there. And we need more resources to be able to do that, I think.
Thank you for that. Thank you both for your excellent presentations. And thank you all, everyone, for joining us. We have our next session is Tuesday, September 19th. We're going to be talking about provider engagement as part of the follow-up from with the recording of this webinar. We hope to have the registration link for that one. And additionally, this is hepb.org and hepbunited.org are our website. So come look at our resources, come email us, and hopefully we will see you at the next session. Thanks, everyone.